Good afternoon, everyone, or good morning if you're on this side of the pond, or good evening if you're on the other side of the pond. So I'm truly honored to be here with you this morning, just in time for my second cup of coffee. And I'd like to share with you both my own personal journey and the journey of evolving fields. I retired from the CDC at the end of 2024, and I wrote this little piece back in the beginning of 2025, before a lot of things happened in the United States. I was reflecting on the scientific situation with respect to the field of public health genomics and my own personal journey. So, and for the next 40 minutes, I'd like to put together my thoughts to you in three buckets. One, sort of the evolution of the fields of genetic epidemiology to public health genomics, tell you a little bit of the stories and adventures in this field. And then the second part will be about the further evolution of the field into what now we call precision public health, which is a controversial idea, but it's been taking roots in the lingo here, both in the US, around the world. And then normally I would have stopped there, but I think the ongoing situation, political and geopolitical in the United States, kind of forces me to think with you all about the changing landscape and how we can together plan for the future of the integration of genomics into public health. Now, my own journey is intertwined with the journey of the fields. I've kind of evolved from being a medical doctor, pediatrician, where I did my training in the American University of Beirut, was fascinated by genetic factors and the field of epidemiology. Wanted to study this a little bit more in depth, and that's why I ended up at Johns Hopkins for a little while studying genetic epidemiology. And then fate took me to CDC, and this is where I've been for the last 40 years. And if you had asked me at the beginning of my career, what would it look 40 years later, I would have told you I have no idea, but I must have been in the right place at the right time, witnessing and contributing to the evolution of different fields. So when I first started, I was really interested in finding out the genetic underpinnings of all diseases, not just genetic diseases, but the field was young in the 70s, was just barely starting, and I want to be a gene hunter, just like everybody else who are discovering genetic causes of disease. But there was some itch inside me that was thinking about there is more than just finding genes. What do you do with the genes when you find them? And so epidemiology was kind of the discipline that allowed me to think and do work on this beyond gene discovery. But then beyond that, the idea of using genetics in both clinical practice and public health seemed like a long shot back in the 80s and the 90s. And I was busy trying to decipher what these fields mean for me, ended up writing a couple of books in this area. But beyond that, when I was at CDC starting my career, the Human Genome Project just started and in 1990, and witnessed both the explosion of information and technology and being a sister agency to the National Institute for Health, had lots of collaborations with NIH. But if I have to encapsulate what the vision, at least conceived by the founders of the Genome Project, in this case, Francis Collins, he wrote this piece back in 1999, picturing what the practice of medicine could look like in 2010. And realizing that we are now 15 years later and that vision hasn't been accomplished, it tells you that Francis was quite optimistic at the time. And I think the idea of a 23-year-old man named John going to his primary care for a regular checkup and ending up with his genetic printout, and then the development of personalized or precision interventions to reduce his risk of heart disease, colon cancer, and lung cancer, still seems some way away. So it tells you that translation of discoveries, I mean, these are fictitious numbers here, but we're not that far from getting these numbers going in practice, at least in some populations. So there is more to genomics than gene discovery and basically gene hunting. So in the 90s, while doing my regular work at the CDC in birth defects and developmental disabilities, the idea that public health could do something in this evolving field was very appealing to me. So I started making enough noise within the agency, formed a task force, ended up writing this early piece on genes to public health. And as a result, we were tasked with forming a small office to try to identify genomic applications that could be used in public health practice, informing various programs, communicating with the general practice and the general public, then integrating ready ideas and evidence-based applications into programs. And, it seems like, sort of obvious, but as we did this, it wasn't clear. I had quite a few, not naysayers, but people saying, well, genomics and public health have nothing to do with each other. And I would have, sort of having the dialogue within the agency and beyond saying, well, what is public health anyway? I mean, public health is whatever we do as a society to assure the conditions for population health. And the way we do it, we have and these are slides from the both the Institute of Medicine in the U.S. and the Public Health Service, looking at the essential public health services, with health equity being a central piece to concerns about population health. So in a way, how we do our work is in three buckets. We assess population health. We discover what the problems are, and try to come up with solutions, develop the right policies, the right interventions, the right guidelines, and then we go about working with the healthcare system and other partners to assure that whatever is ready can be disseminated, can be implemented, can save lives, and can prevent disease. So it's easier said than done, and the U.S. has a complicated public health system, or had until now, which has now been quite simplified as a result of recent changes in the government. So the public health services and the essential functions were our guiding principles in trying to figure out what to do with genes when they came out of the discovery bandwagon. So early on, we set out this sort of intuitive translational pathway from bench to outcomes. And, we're not the only ones writing about this. This has been written about multiple times in multiple settings, not just in genomics, but the idea that you go beyond the bench to the bedside, which is sort of the traditional biomedical model, to try to evaluate in the second step what works and what doesn't work, develop the right recommendations and policies, and then use the tenets of implementation science in the third step to implement whatever works in both healthcare systems and public health programs, and then watch it, look at outcomes, do effectiveness, do surveillance, and then close the loop between discovery and population health outcomes, with knowledge integration and synthesis in the middle of this. So this is not a static model. And early on, when we came up with this idea, we looked at both the biomedical research funding and what's been published. It turned out very little was in that second step. That's why in the paper we called it the road less traveled. Things have gotten a little bit better in the last 10 years, but still, we're not investing enough in beyond the bench to bedside, both as a country and as a world in general. And if I have to encapsulate 25 years worth of work in just one word and one image, that would be about collaborations. These are just three random collaborative enterprises that we launched from our office at the CDC and beyond. The top right corner is about collaboration between schools of public health and state public health departments in the US. We formed a network, and this was in 2008. This is in 2018, where we convened an action collaborative in genomics and population health through the National Academy of Medicine. And this one here on the left lower corner is close to my heart, because this picture, which is fairly, I'm not sure you will see it very well, but you might recognize my friend Ron Zimmer in the front here. This is Bellagio, 2005. That was the beginning of a long-standing international collaboration that continues to this day about trying to figure out both the policy and the goals for the field of public health genomics. So a lot happened in the last 25 years. Unfortunately, 40 minutes doesn't even have enough time to cover even one of these, so I'm going to move on, but I'm happy to answer questions about each and every one of these. But early on, what we were about is collecting data at the population level and then reflecting it back to programs and discussing what can be done. Because in the early days, there was very little to do. We had a very vibrant website, which has been taken down now. We had a very vibrant blog enterprise within our office. We educated and trained scores and loads of public health professionals and generations who are now becoming leaders in the field, developed tools like the Family Health Portrait, a Surgeon General tool in the US to try to get people to collect their own family health history and share it with their healthcare providers and so on. But one of the things that I'm most proud about is this knowledge integration piece. We call it the EGAP initiative. EGAP stands for the Evaluation of Genomic Applications in Practice and Prevention. It's a mouthful, but the idea is to try to look at that center of the translation pathway and determine really what works, what doesn't work. And guideline development is bread and butter in both clinical medicine and public health. And so there was nothing in the field of genomics that allows this sort of a holistic view of the field. So we did an experiment. We modeled an independent panel after the US Preventive Services Task Force, which is a well-known government funded entity that looks at preventive services and decides what works and what doesn't work. For 10 years, we were able to not only look at the field, but I mean, the committee, which is represented here in this picture, looked at ways to evaluate evidence, to do systematic reviews using a framework which we call fondly the ACE framework. ACE stands for Analytic Validity, Clinical Validity, Clinical Utility, and ELSI. That's another mouthful, but the idea is for whatever intended use of the genomic technology or applications, you evaluate it, just like we do in other areas of medicine and public health. The group came up with 10 recommendations, but more importantly, they set out the standards for evaluation in the field. So once they were disbanded in 2014, other groups picked up the mantle and were able to use whatever they achieved to continue this journey. Now, since then, we developed a simple schema, and the simple schema of the tier 1, tier 2, tier 3 is still valid to this day. People continue to talk about the CDC tier 1 applications. And the idea came to us fairly simply because as we went around public health programs, they will keep asking us, you know, what's ready, what's not. So EGAP was an experiment. They came up with one tier 1 application, two tier 1 applications, but there are other evidence-based groups that produce recommendations. So what we did for the last 10 years is to review the literature and then insert in buckets what's ready, what's not, what's in between. And I'd like to tell you a little bit about some of these as we go along. I mean, if you see newborn screening, hereditary breast ovarian cancer, Lynch syndrome, but for a long time, most of the genome was in the red, meaning not ready for implementation. The field of pharmacogenomics is kind of inched up. I mean, this is not a static imagery, but applications keep moving back and, you know, mostly going forward. So for at least the last 10 years, we displayed this database online. Now it's been taken down by CDC, but written a couple of papers. This is a summary of the evolution of Tier 1 applications in the US. And there are different ways you get to have designation of Tier 1. One is if an evidence-based group such as EGAP or the US Preventive Service Task Force does a systematic review and says this is ready for application because it can save lives. The other two mechanisms are through the FDA, Food and Drug Administration, or CMS, the Center for Medicare and Medicaid Services, that reviews also the evidence. So in the last, these are all new applications every year. There are not that many, only a handful every year, but there are now a couple of hundred that cross that threshold of higher evidence, if you will. So I wanted to give you some examples of where we are and how the field has kind of evolved in this space. So newborn screening is, of course, the largest Tier 1 public health genomics program in the world. I mean, it was a Tier 1 application long before the word genomics was slapped to this enterprise. From the 60s and on, 5 decades of population-based screening at birth using newborn blood spot technology, starting with phenylketonuria and adding dozens and dozens of conditions. And this is truly a public health program in the sense that it's run by states within the US. It covers all the newborns, about 4 million births every year, identify thousands of babies with one or more of these 30 plus genetic, metabolic, and other disorders. Now, this field is being upended or supplemented or complemented with the applications of either whole genome or selected genome sequencing at birth. So the story is being written as we speak. There is a new newborn screening program in the horizon that is based on genomic technology. Don't have time to debate the pros and cons. We're not ready for it, but there are multiple programs around the world, certainly in the UK and the US, exploring the utility of adding sequencing to newborn screening. The only thing I would leave you with is that newborns have no informed consent power. They cannot decide for themselves. So basically, parents have to decide for them. So the ethics of sequencing newborns is a little bit different than the ethics of sequencing adults who can provide informed consent as they go along. Now, as we jumped into Tier 1 applications for the last 10 years, and this is based on our strategic planning back in 2012, we focused on 3 conditions and added the 4th later on in the last decade: breast cancer, ovarian cancer, Lynch syndrome, and familial hypercholesterolemia. Collectively, these conditions affect at least maybe 0.5 to 1% of the population in the US. Most people do not know they have these conditions. So there are evidence-based guidelines that both around screening and cascading in relatives. So we worked with heart disease program, the cancer program, the blood disorders program within the US to try to integrate those conditions into practice. Next slide. And this slide illustrates sort of the tension between medicine and public health. Programs in cancer have breast cancer and screening. And of course, hereditary breast ovarian cancer due to BRCA1, 2, and 3 mutations account for only a percentage of the cases. So should we worry about implementation of screening in general or focus on the few that have very high risk? Same with Lynch syndrome, which is a cause of colorectal cancer and endometrial cancer. So a minority of cases are due to these genetic conditions. But in terms of absolute numbers, if you look at the new number of cases per year, even these 2 conditions eclipse the yield of newborn screening. So in other words, if you screen adults, you might be able to come up with people with these conditions for which you can have prevention strategies that allow reducing of that risk. So, the answer in whether you focus on the whole population or the high risk is obviously in both. Nobody should do one versus the other. So we did, and we worked with the cancer program within the CDC, and we funded states, in this case, the state of Michigan, and integrated public health genomics into their cancer prevention strategy. As a result, at least in between 2000 and 2008 and 2013, the outreach and surveillance allowed for more and more cases of BRCA-related cancers to be diagnosed, people at risk, had counseling and the right interventions. But one thing which continues to this day is sort of the disparities within the population, and that's a theme I'll come back at the end of the talk. In this case, we continue to do surveillance for utilization of BRCA and BRCA test in the United States. This is data from large claims database in the US, reflecting the differential between rural and urban areas and percentage of rate of utilization of BRCA test. And so just want to get your attention here to this point in 2012. What happened in 2012 when everything jumped up, both rural and urban, was the implementation of the Affordable Care Act in the US, which is called as Obamacare. And what happened in 2012 also was a decision by the Supreme Court to basically throw out the patent on BRCA testing by one company. So the result of lower prices and the Obamacare coverage of BRCA2 testing, we see that the pace and rate of BRCA testing picked up in the US, but still that differential exists to this day. Just switching gears to familial hypercholesterolemia. It's really a prototype tier 1 application because it's common enough. It leads to early heart disease from defect in LDL receptor and other genes that lead to lifelong high levels of LDL cholesterols. And there are evidence-based recommendations for cascading, for picking up FH, in early adulthood and intervening with statins and other drugs to reduce the risk of heart disease. And I just wanted to draw your attention to cascade screening for a minute. This is from a paper we wrote with Josh Knowles back in 2017. This is a fictitious pedigree, but it illustrates the complexity of doing cascade screening in a population like the US. Maybe in smaller populations like the Netherlands, which did cascade screening for many years, it's very hard to do cascade screening in 50 states, multiple health systems. And so the knowledge of having one proband with FH leads to multiple cases and living in multiple states is a challenge to this day for how to implement. Happy to discuss that later. Now, of course, I can't go too far with this field without mentioning the field of rare diseases, because rare diseases have emerged as the low-hanging fruits of public health genomics applications. There are obviously thousands of rare diseases collectively common, affecting millions of people around the world. There's plenty of evidence now that shows that applications of next-gen sequencing will allow the diagnostic odyssey to be reduced, even the yield of sequencing in terms of diagnosis and in some cases treatments and interventions, and as more gene therapy gets on the way. I think rare diseases will be a prototype for public health genomics. And I just want to give a shout out. This paper just came out last week. from the UK, as the 100,000 Genome Project kind of moved from research to routine clinical practice. More and more cases in pediatric cares are being diagnosed, and simple clinical service delivery, higher clinical diagnostic yield, and early age at diagnosis. And this has been replicated in other countries around the world. Now, there is a lot of talk about pharmacogenomics, and pharmacogenomics is not just one thing. It's obviously multiple applications that could be used for treatment, prevention, etc. For the most part, it's still a tier 2 application, but there are pockets of tier 1 in pharmacogenomics. There's been quite a bit of discussion about the progress and the challenges in implementation, but there are pockets of implementation that make sense in 2025. Finally, I think one of the promises of the area of public health genomics in the field is population-based screening beyond the newborn period. And I think, as we think about screening large-scale populations for genetic risk for different conditions, we have to keep in mind that there is a high bar of evidence. The Wilson and Younger WHO criteria, written back in 1968, come to mind. They have been massaged and changed over time. But for the most part, we're not ready for population-based DNA screening. But the talk about trying to bundle up a few tier 1 applications and coming up with a panel that could be worthwhile screening young adults is an idea that's now being empirically tested in different populations and health systems, both in the US and Australia, around the world. I think the promise of public health genomics could be fulfilled between rare diseases and the population-based screening for some of the tier 1 applications. Last but not least, can't run away from polygenic risk scores because they're all over the place. What tier are they? Are we ready for them? For the most part, they're still tier 3. Some people may vehemently disagree with me, but there is a lot of unanswered questions about them. There may be some of them, like with heart disease and certainly breast cancer, they have inched up to tier 2, perhaps inching towards tier 1. This state of the science paper was written now 3 years ago, but there's been a little bit more progress since then about the state of the science and polygenic risk scores. Potential benefits are great because everybody has a risk score for something, and why not use it? The difference between polygenic and monogenic is obvious from a public health perspective. Monogenic affects the few, whereas polygenic affects us all. So why not? And so it's a very intriguing thought. But there are potential challenges, uncertainties, biases, misunderstanding, misuse, unrepresented populations, etc. So there are gaps in best practices as of today and risk communication and regulatory frameworks. So I took you on a whirlwind in the last half an hour. I still have a little bit more to cover. So let me slow down and just share with you, after 25 years of experience of public health genomics in the US, before I retired, we took stock and looked at the field and saw major challenges, specifically 5 challenges that allowed or slowed the integration of genomics into public health program. The first one is the obvious one I just talked about, which is, well, genomics is about the rare. We in public health have much more bigger fish to fry. We have to, prevent all breast cancer cases, not just the few. So why should we spend more energy and resources in the field of the rare? So that's number one. Number two, wherever you go in public health, you hear about, and I agree with, the social environmental determinants of health. So is the focus on genetics taking away from the social determinants of health? And again, my answer to that is no, because everything, the intersection between genetic and environmental factors could be explored in public health programs. One does not diminish the importance of the other. The third one, which is very interesting, I've encountered at CDC, like, well, I mean, genetic factors are non-modifiable. Therefore, why should we focus on them? And, your age is non-modifiable. Your ethnic background is non-modifiable, but yet we have multiple public health programs that focus on different age groups. So there's nothing inherently contradictory in the idea of focusing, interventions by genetic background. Number 4, which was very important, but now seems to be changing a little bit. When we first started, there was very little to apply. The evidence wasn't there for use and practice, but that was in the 90s and the early 2000s and 2010, but we are in 2025. There are plenty of lives that can be saved with public health genomics right now. Yes, it is still about the future for the most part, but the promise can be implemented now. And finally, this is sort of my favorite one, and speaks to the idea that there is a schism between medicine and public health. Well, why should we worry in public health about genomics? Let the healthcare system worry about it. There is no need for public health programs to be involved. And this paper was written with my friend Ron almost 20 years ago about widening the schism between medicine and public health, and the idea that public health focuses on the masses, the medicine focuses on the patients one by one. I think we can do both, and public health has a way of making sure that healthcare delivery occurs in a meaningful and an impactful way. So, having gone through 25 years worth of information in 25 minutes, I probably lost most of the audience here. The field kept evolving. So I want to move on to the next part of this journey, which was started kind of in the middle 2010, when people started talking about personalized medicine and precision medicine. And, and I'll just tell you a little bit about my take on this. So, I mean, we hear about personalized, precision, stratified, individualized. All of these words are being batted around. But just to share with you that public health is resistant to the idea. My friend Sandro Galea, who's the Dean of School of Public Health right now at Washington University in St. Louis, and I debated this issue. We even wrote a paper about precision medicine and population health back in 2017. If you ask the question, will precision medicine improve population health? He said no, I said yes. And we ended up having this pro-con discussion. And then, he persevered because I thought we reached some common understanding. He gave this talk back in 2022 or 3 in Sydney, Australia, about the word precision being an oxymoron in public health, which I know it's not. And let me tell you why. So just like genomic medicine works with public health genomics to try to deliver the good in genomics, over the last 10 years, and certainly now, we are witnessing the explosion of data of all sorts, from the exposome to the different markers to GPS information. This data in totality, beyond genetics, will allow us to one day use the information to deliver, more therapeutic interventions at the individual patient level and more population level interventions at the population level. So public health genomics is naturally evolving into precision public health, just like public health genomics, in which we look at the effective and ethical, responsible use of this information at the population level. The same thing can be applied to other types of data, not just genomic data. So this is where we are. So the question is, which is still a work in progress, is can we deliver the essential public health services with more precision? And what do we mean by more precision? I mean, we're not obviously delivering it one person at a time. That's precision medicine, but more guiding our interventions to people who need it the most. So we can guide our surveillance to measure population health problems with a bit more clarity, granularity. Instead of looking at the whole population, you can divide into subgroups, stratify. Can we target our policies to different subsets of the population, and then can we make sure that the right policies reach the right intervention, the right population? So going back to my roots in epidemiology, it's all about person, place, and time. So this has been my guiding principle. You describe and you look at population health from the point of view of a person, of where that person lives, and over time. And right now, I can tell you that for all of these three axes, we have more data coming at us in so many ways, certainly now guided by machine learning and artificial intelligence, and much more in the next years. So this would behoove us and force us to think a bit more clearly and try to prepare for a future in which the combination of place, person, and time could drive interventions in a more stratified way, not necessarily precision way in terms of N of 1. So these are some of the ways you can end up with more precision at the individual level. So I even wrote about this back in 2016. At the time, said, well, there are three priority areas for this field. Shifting the first one, which is the obvious one, is trying to shift focus from treatment to prevention, which is a tenet of public health. So instead of focusing on just treatment of one person, one cancer cell at a time, let's focus on prevention at the population level. The second priority is, in order to do more precision, you need to modernize public health practice and the programs and the data systems to allow interoperability, movement of large-scale data going from electronic health records to GPSs and genomics. That the structure for doing precision at the population level did not exist in the mid-2010, and now it's being built as we go along. And the third, which is the low-hanging fruits of precision public health, is pathogen genomics. Pathogen genomics has actually, people in public health understand it much more intuitively than human genetics, because it's part and parcel of what we do. We try to track pathogens, viruses, bacteria, etc., at the population level. And if we can use the tools of sequencing, like in this case, CDC developed a whole program called the Advanced Molecular Detection Program, and that recently celebrated its 10th anniversary, and with a series of papers in the journal Emerging Infectious Diseases, shows you in much detail on how genomic sequencing has allowed detection of outbreaks, certainly during the COVID pandemic, tracking of the SARS-CoV-2 variants over time, and then allowing the right interventions, in this case vaccinations, to target the right variants. To me, that's an exercise in precision public health that people in public health understand more intuitively than the human counterpart. Before I deal with the last segment, I've always been suspicious of this data field. And this is a paper now 11 years old. I mean, I reread it the other day and I said, wow, I mean, we're still in the early days of big data meeting public health. And the tagline is that we're still under the idea that human well-being could benefit from large-scale data if large-scale noise can be minimized. So that summarizes my thinking about this, because there are biases in data. If you collect the, garbage in, garbage out, of course, artificial intelligence have a way of self-correcting now. There are issues of equity and disparities. If you have different data by different subpopulations that could not be interpreted or interpreted the wrong way. And implementation is the key, because how do we put these things in play? And I just want to leave you with an example that I still use. It's now almost 10 years old, from the early days of machine learning and AI, and it's about obesity. And obesity is a problem worldwide, certainly in the US. And there are different ways of predicting who will be obese so that you can develop interventions. In this case, starting with the micro all the way to the macro, this paper back in 2019 looked at polygenic prediction of weight and obesity trajectories from birth to adulthood. Don't have time to go through the area under the curve or anything, but it's pretty good. Polygenic risk prediction is not bad for putting a number, at least, on who will end up to be overweight and obese just from polygenic risk scores. You can also predict and looking at electronic health data, even without knowing the BMI of a person, you can do a lot of prediction. In this case, there are areas under the curve that look pretty good of using electronic health record to try to predict who is obese and who is not. And finally, the kicker for me was this paper back from 2018 that reads something like this: artificial intelligence spots obesity from space. And that, I just want to slow down for a minute and tell you that this, in the early days of machine learning, these people looked at in two areas, Los Angeles and Seattle, and based on images of from outer space of physical neighborhoods, highways, greeneries, crosswalks, etc., were able to show and correlate actually with real data on BMI from the CDC behavioral risk factor surveillance that without going into measuring BMI on anybody, you can look at LA neighborhoods and Seattle neighborhoods and say, aha, this is where we have an obesity problem without even going into the community. So why am I telling you this? These three examples is because there are so many ways you can predict, and artificial intelligence is getting better and better at trying to allow you to move into more prediction. But precision public health is more than just about data. And I like this quote that was published recently in the BMJ from our friends who did the Precision Public Health meeting in Asia recently. And so data is not enough. We need action, and we need action that is equity driven. So as it stands, precision public health risks becoming a technocratic fix to a deeply political problem without confronting the unequal distribution of power shaping health data, big data, AI, etc., exacerbating the inequities. The precision public health may do more harm than benefit. Why am I telling you this? Because we are where we are. And I want to take the last few minutes to tell you about our evolving story. I retired at the end of 2024. 2025 basically has witnessed the dismantling of both science and public health. Certainly, the Public Health Genomics office at CDC doesn't exist anymore. It was disbanded along with thousands of other employees losing their jobs, multiple programs that are even more important than public health genomics, like smoking and health and lead poisoning and immunization, etc. And, I've always viewed that politics and science always intersect. And our challenge has always been to try to put the best foot in science with the right framework of politics to help most people as much as we can. These two papers was just published this week, and I didn't even have time to finish reading them, but they basically tell the story about where we are right now in the US. Certainly, the CDC is on a respirator right now. This paper was written in The Lancet 2 weeks ago by 3 leaders of CDC who retired or forced to resign. And there is a big question mark as to whether or not CDC as a public health agency can survive the next couple of years, or at least 3 years, because of all the political underpinning. So certainly, that if you put in buckets where we are with the cuts in science and funding, this investigation in the New York Times found fewer grants in every area of science and medicine, more competition for funding, a drop in grants mentioning diversity and equity. I'll come back to that in a minute. fewer fellowships for future scientists, cutting the pipeline for the future. And many experts worry that recent funding cuts may threaten America's role as global scientific leader. So the attacks on diversity, equity, and inclusion are real. Lots of programs and funding has been cut, both at CDC. Just wanted to draw your attention to two papers I was involved with. The second one here on the right-hand side was an editorial I co-wrote with two editors of two different journals, the Journal of Community Genetics and the Journal of Public Health Genomics, showing that we cannot achieve the vision of genomics to improve health for all unless we include the various subpopulations and diverse populations and the whole translation scheme from discovery all the way to applications. And we recently gave a symposium on this as part of this discussion. This paper was written during the COVID pandemic, focusing on health equity, which really was very apparent during the pandemic as who died and who lived as a result of COVID-19. This is very much related to genomics in a direct way because the dismantling of evidence-based recommendations and policy, in this case, the ACIP, the immunization practices, the newborn screening panel in the US that allows deciding which conditions to be added to the newborn screening panel, basically leaves us with no way of doing that translation pathway. In other words, lack of evidence-based information would lead to proliferation of misinformation, which we are seeing now in a heightened way, especially around vaccines, around autism, and other things in the US. Cuts in global funding have already affected many parts of the world. The US going out of WHO and other things have and will essentially lead to thousands and millions of people losing their lives as a result. So I don't want to end up on a downer because I believe that the way forward is very clear if we can buckle up and continue with this journey together. And we need to start involving other actors in the public health system. 9 former CDC directors wrote this piece back in September about trying to, these are the actors in the public health systems, the governments are only one part of it, but these other actors, community and academia and the healthcare system, need to step up in the meantime as long as the government is dormant and continue to do the oversight authority that is delegated in the political arena. In the meantime, global science may have to continue for a while without the US or with a more limited role for the United States, which is always, I mean, it has some benefits, and this paper expressed the idea of de-Americanizing global science, and basically the rest of the world can pick up the mantle and run with it, and in a way, this will increase the representation of human diversity in medical studies, among other benefits, could also improve science as well. The global collaboration and philanthropy, I mean, the Gates Foundation, Bill Gates wrote this piece recently in Nature Medicine. He was funding a major consortium in Alzheimer's disease and genetics and proteomics. And basically, they have to step up a little bit more. But even Bill Gates said at the end, unfortunate truth is that no individual or private organization can fill the gaps left by governments. So at the end of the day, we have to, get government to get going again. So I want to end up with this last quote because it really influenced me. Francis Collins recently retired from NIH as a result of the upheaval within NIH, and recently gave this key talk at the American Society for Human Genetics. And just let me read it for you because it impressed me. And he said, and I quote, "Let's be clear. We're on the right side of history to pursue fundamental knowledge about our biological essence, to insist that work has to be inclusive of all peoples, to commit ourselves to using the most rigorous science and the highest ethical standards, to find ways to relieve suffering, to diagnose, treat, and cure disease. even as you grieve, as I do, about the present circumstances, never give up hope that a brighter day is coming. Let us be people of action, great science, and that will give hope for a hurting world. So this is my last slide here. We'll give us a few minutes for Q&A. You know, when I wrote The Journey Continues, that piece, which predated all the political stuff going on, I could have written it in retrospect as The Journey Stops. But no, the journey continues, regardless of what happens to one office and one institution and one agency in one country. And as we move from genomics to precision and other big data, there are public health, meaning public health, and has to be at the table in order to implement all this technology. And we need to ride this current wave of policy and politics interfering with our current ability to do that translation. But I have no doubt, and I've had this conversation with multiple people over the last year, that the journey will continue, because as more and more applications move from the bench to the bedside and have enough evidence for applicability to different populations, we're going to see more of the golden days of public health genomics ahead of us.